The Exit interview series launched this fall is exploring the policy and political record of the Obama administration with the cabinet secretaries and other senior administration officials who have built that record. Our interest is in how these policy actors themselves see the challenges they faced and what they've learned in addressing them, what they'd advise their successors based on their experience. True to GU Politics' mission, we'll also be hosting a counterpoint conversation from experienced policymakers who just might have a different point of view. So stay tuned for details on that event, and please know that the whole series will be published as an oral history of the Obama administration. Tonight, with Health and Human Services Secretary Sylvia Burwell, our focus is on health reform and health care. Safe to say, one of the biggest challenges this administration has faced, both politically and operationally. Why is it such a challenge? When President Obama came into office, we were approaching having 50 million people without health insurance at risk of not receiving health care when they needed it. And costs were rising rapidly. A terrible combination and a problem that had persisted for years and was only getting worse. Why was it so hard to fix? I can tell you a little about it, having been part of trying to fix it in President Bill Clinton's first administration. We were both there, Secretary Burwell and I. It's because most of us have health insurance through our employer, Medicare, Medicaid, and it's really easy for opponents of active government to scare us into thinking that bringing in the 15% who've been left out, mostly low and modest income workers who don't, and their families, who don't get coverage through their jobs, will make our lives worse. Now, we in the Bill Clinton administration did the Obama administration a great service, not sufficiently recognized. Our effort offered them a model demonstrating exactly what not to do if you wanted to pass health reform. And they used that example very well, tailoring the Affordable Care Act not to disrupt most people who have coverage while extending coverage to those left out. To me, and I do get my minute to tell you what I think, the results are amazing. 20 million people newly insured, receiving good care, with per capita costs rising more slowly than any time in history, despite what you're reading about the spike in marketplace premiums that I'm sure will come up tonight. But no question, the job of getting everybody affordable, meaningful insurance is not done. That spike in premiums, again, only marketplace premiums, which are heavily subsidized, reflect lower enrollment than we'd like to see. Insurers are unhappy. Consumers who are not subsidized face premiums that are unaffordable. And benefits are shrinking as out-of-pocket payments rise, not only in marketplace plans, but in employer-sponsored insurance as well. And then, of course, there's the Medicaid coverage gap, a reflection of political opposition to the expansion of coverage that just won't quit. So there's lots of work left to do and lots of political challenges left to face as the Obama administration passes the torch. And I can't think of anybody better than the esteemed and highly respected Secretary of Health and Human Services, Sylvia Burwell, to share her views on the challenges faced and the challenges yet to come. So I thank you for being with us tonight. I know we're going to have a fabulous discussion. And now, to get a proper introduction for the Secretary, let me turn the podium over to Allie Ross to introduce her. Thanks so much.
Thank you all for being here today. I'm Allie Ross. I'm a freshman international health major here in the School of Nursing and Health Studies. So like most of you watching, I came to Georgetown because I love pretty much everything about politics and government in general. The Institute of Politics and Public Service here, from its Fellows Program to the Exit Interview series, has so far provided all the access to that kind of stuff that I wanted, and even more than I could have possibly thought. So whether you're a student or a member of the Georgetown community, I can't recommend enough getting involved with them through different volunteer opportunities like Special Ops or Research Squad, Fellows discussion groups, or other events with GU Politics. That said, I'd like to introduce today's guests. Our moderator is E.J. Dion, a Georgetown professor in the Foundations of Democracy and Culture. Currently, he's a senior fellow at the Brookings Institution and a syndicated columnist for the Washington Post. An esteemed commentator on politics, Professor Dion also regularly appears on National Public Radio and MSNBC and contributes to NBC's Meet the Press. Previously, he's worked for the New York Times, written several acclaimed books, such as Why Americans Hate Politics, and won numerous awards for his contributions to journalism. With Professor Dion today, we have Sylvia Matthews Burwell, the current Secretary of Health and Human Services. Appointed in 2014, Secretary Burwell has been front and center in defending and improving the Affordable Care Act for the Obama administration. Previously, she's led many prominent organizations in both the public and private sectors, having served as the director of the Office of Management and Budget, president of the Walmart Foundation, president of the Global Development Program, and chief operating officer of the Bill and Melinda Gates Foundation. Secretary Burwell has served on the boards of the Council of Foreign Relations, MetLife, and the University of Washington Medical Center, among others, and she held many different positions during Bill Clinton's administration. Lastly, before we get started with the third installment of the Exit Interview series, we'd like to encourage you all to keep your phones out and join us on Facebook, Twitter, Instagram, and Snapchat at GU Politics with the hashtag #TheExitInterview. And now, please join me in welcoming Professor E.J. Dion and Secretary Burwell to the stage.
Congratulations. Thank you so much.
Good to meet you. Thank you.
Good to meet you.
Thank you so much. Thank you so much. Thank you. Thank you.
I want to say it's a great honor, a great and intimidating honor to be here tonight. I want to thank the Institute of Politics, which is doing great work. And I do want to point out for the record that the Institute of Politics is open and fair and will be, as I think Judy pointed out, we're going to have both sides of the Obama record, although after Secretary Burwell's done, she might achieve a miraculous conversion of all critics of the administration, so the Republicans will have something different to say than we anticipate. But we are going to have all of that. I have to say that with Secretary Burwell, who knows so much about social policy, I was very intimidated about having to do this. And my mother-in-law, I have a wonderful mother-in-law, 85 years old, who's visiting us. And when I left, I said, I have to interview Secretary Burwell in front of this serious group of people. And she said that she would pray to St. Francis de Sales, the patron saint of journalists, that I might do a good job. So whatever good here comes from St. Francis, but his office issued a statement saying he's not responsible for any of my errors. It is great to be with you. And I would love you to begin I want to start with a couple of very general questions, which is, what in the world did you expect when you got into this job? I mean, you've held so many positions in government that you knew you had a good sense of what you were walking into. You also were walking in at a time of some difficulties that you had to help resolve. And then I'd just like you to do a bit of a balance sheet about what you think, some of the things you're proudest of, some of the things you wish you might have been able to do, and then we'll take it from there.
Thank you, and thank you, EJ. In terms of when I took the job, I think as you reflected, it was a time where there were a number of challenges, and it was clear that that was something that I needed to work on in terms of the work that we needed to do in the marketplace. And so that was one thing that was very clear as I was going over. I was fortunate that I had been at the Office of Management and Budget, and so I had a chance to see the breadth and depth of the Department of Health and Human Services. It's over $1 trillion in terms of the department. If we were an economy and you measured us in terms of our budget, our annual budget and GDP, we'd be the 17th largest country in the world. It has, just FDA alone regulates 18% of all consumer purchases, the Food and Drug Administration. So it's very broad and diverse. The Administration for Community Living, National Institutes of Health. And so I knew those pieces and parts. I think some of the things that I didn't know, I had been told, and my predecessor, this was one of the things she emphasized, is the passion that people have for their work there at HHS. And it was interesting because I've been fortunate. You know, I worked at the Gates Foundation. I've worked in another administration as well. But it is really true at HHS, people consider it a mission. You know, it is their life's calling for many people that are there. And that's been a wonderful surprise. You asked what I expected, but there have been surprises. The other surprise, you know, if I'm honest about it, is that there were so many things that came at once in terms of unexpected. When I arrived at HHS, the unaccompanied children were backed up at the border. In addition, Ebola. In addition to the issue that, you know, the Affordable Care Act, I'm working on that. So there were some surprises in that way. When I answer and think about the question of what are some of the things I'm proudest of, because the department is so diverse, certainly, and part of why I went was to be a part of the transformation of the US healthcare system. And the work that we've done there and the impact that we've had there that I've contributed to is probably one of the things I'm most proud of. But fortunately at the department, there are things big and small. And whether that's our Head Start regulation that went out, and it's the first time basically since I was in Head Start in the 1970s that we have done an overhaul. And this overhaul reduced our regulations and what people have to do by a third, 30%, almost a third in terms of what we did. We've moved to better standards for teachers for a full day, all evidence-based. And so it really isn't one thing, it is what the department does every day for the issues that people care about around their kitchen table. So, and I would be remiss if I didn't mention all the work in global health security. And what that means is when we have things like Ebola and Zika to handle. So many things in terms of, because it's an incredible place to get to work on such a broad range of issues that really affect people's lives daily.
Could I ask you, you worked in government in both the White House and in the federal government in the 90s. Could you talk a bit about how dealings with Congress have changed? And I'm thinking of a couple areas, and this is also how I want to back into the news of the week in terms of Obamacare. Ebola was, that happened to hit right before an election, and it became an election issue. And then in the end, you know, most of the reviews I read said that our government actually did a pretty good job of dealing with it. And as soon as it ceased to be an election issue, everything got completely lost. So that's one area. Second area is on confirmations, where the whole confirmation process has gotten all fouled up over a long period of time. And then the third area is fixing what's wrong, and that's where I'll get to Obamacare. Maybe we can get to that next. But could you talk about your experience of Congress, both earlier and, you know, in recent years?
I think it is fair to say that it's harder. And it's harder, and I think actually members of Congress would say it's harder, and it's harder to get things done. And I do see and experience that. I also see and experience there are still great people that you can work with to get things done, and we've been able to do that in a number of areas. But the way that issues, one's ability to discuss and get to the core substance of an issue. Obviously, we have disagreements about policy in the United States. That's natural, that's a healthy part of our democracy. But our ability to have the conversations, and what I like to say is, can we put the point on the arrow in terms of what we disagree about? You know, we believe that this is a bigger priority than that, is often the way these conversations if you get to the substance, and that is missing, and even the fora to do that. Although I will say, on some of the issues you've mentioned, it's very interesting because sometimes there are actually meetings instead of hearings, and that's where you can have those kinds of very real conversations. But I think I like to say that I think the proximity to substance changed in the intervening period when I was away from Washington, D.C. And that makes things harder across the board.
And why do you think that happened?
I'm not sure. I think, there have been an evolution of many things. And actually, at one point when I finished my time in England, I actually wanted to get my PhD. And what I wanted to do, I had two different things that I actually wanted to pursue and write about, actually very different. One was the idea of the question of the state, and that there would become a rise in players that weren't really state players. And that you could see this already happening, that there were going to become these entities that would be as powerful as states, but wouldn't be states, and how would we deal? So that was one whole area if I did it in IR, in international relations. My undergraduate degree was in government. So the second area, and it relates to this question, is I believe that at that time there was an evolution that was already happening of pushing people into single issue, into reacting in their politics about single issues. And this was the beginning, at that time, direct mail. And now, direct mail, with technology, it's like we've gone, completely steroids on that. But because you could be targeted for the NRA, and you could be targeted for choice, and you could be targeted, and so people were getting into their little lanes. And this was exacerbated when you reduce the power of the committee. The committee is the means by which in government that we bring ideas and people together in the way I was describing. And so I think there are a number of factors that have contributed to both the body politic and the functioning here in Washington that lead to some of this lack of proximity to substance.
See, we could consider this your declaration of candidacy for the Senate, sometime in the future. And your thesis sounds... Your thesis sounds like Judy Fader's PhD thesis a little bit.
Perhaps a preview of what I might do in the future. Maybe I'll go back and get that PhD.
Maybe you should come to Georgetown. Let's go to the problems with Obamacare. I can imagine critics on the one side saying, why couldn't you foresee this? Why couldn't you do anything about it? I can imagine a lot of Democrats on the ballot saying, couldn't you have announced this on November 15th? But we won't go there. So what is your view of what the problem is and what kinds of things could we do to solve it?
So the first thing that I think is important to this conversation is to put it in context in a number of ways in terms of the problem. Because the Affordable Care Act was about three things: affordability, access, and quality. And it was about all citizens in the U.S., not the group of people, which were very important, that were uninsured. And when we think about where we are, the quote, the problem, I think it is important to think about where we were and where we are now. So let's just do access. 1 in 7 Americans did not have insurance. 20 million more Americans now have insurance. We have the lowest uninsured rate in the history of our nation. That's access. In terms of quality, and I think this is a very important part that gets missed about the Affordable Care Act, because if I actually asked, everyone, we're going to have a piece of paper, and I want you to write down how your benefits changed, because I'm assuming you were on your parents' care, many of you, and so how your benefit, what changed from the Affordable Care Act, and how many people actually would go through and know that you no longer, I'm sure everybody here knows somebody with asthma, somebody who's had cancer, somebody who has an eating disorder, somebody who has a pre-existing condition. And no longer can you not be insured. So for those of you who are graduate students and you're 25 and your 26th birthday's about to come up, well, first of all, you wouldn't have been covered because you couldn't be on your plans to 26. Second of all, in terms of pre-existing conditions. Third, Many of you all probably don't know that there were things called annual limits or lifetime limits. And let's just take lifetime limits. I've met the kid who was 15 and had had cancer and hit her lifetime limit of insurance if we didn't have the Affordable Care Act. I've met the mother who, she's like, well, I just decided, because I'd hit my annual limit, this was before the Affordable Care Act, that I wasn't going to get that last chemotherapy treatment until the next year, because I'd hit it. And so the progress that's been made on quality across the board, or most people don't know another nerdy one, which is harms in hospitals. Those are bed sores, falls, things that shouldn't happen. They've been reduced by 17%. That's 87,000 estimated deaths not occurring and $20 billion saved. And so the quality progress, and then affordability, because that brings us back into this part of the conversation. So this will bring us, so first on affordability, I think it's important to recognize that if we had continued on the trajectory that we were on in terms of Medicare spending, so this is before the Affordable Care Act, the growth that was occurring in Medicare spending, we would have spent $473 billion more. $473 billion. For any of you all who are studying the budget of the United States government, any of you all have studied something called Simpson-Bowles? Look at the numbers. That is an incredible amount of savings for the federal government. And then let's talk about people and their health care. So, and this will bring us into the premiums. So 150 million people are in the employer-based market. For these people, the premiums that we're talking about and we're going to talk about don't affect them. But for that 150 million people, in the last 6 years, we've had 5 of the lowest years of premium growth on record. So if you're in the employer market, that's the slowest growth that you've seen since, during this period of time. So that's 150 million Americans. And then there are the 55 million Americans in Medicare. They're not impacted. And then there are the 70 million Americans in Medicaid. And they're not impacted. So let's go to the marketplace, the problem that I think people are focused on. So in the marketplace, when we look at that group of people, 10.5 million in the marketplace, 85% of those people receive tax credits or subsidies. And the way the system was designed, it was designed so that when premiums go up, your tax credit goes up. Because the whole idea behind the tax credits or the subsidies is that you're going to pay, we don't want you to pay more than a percentage of your income. So if your income stays the same but your premium goes up, your subsidy goes up. And so that's the way the system was designed. And so in terms of the, quote, problem, I think one of the problems right now is making sure people have the right information so they can make the right choices. And so we know that right now in the marketplace, for people that come back, 72% of people can find a plan for $75 or less. They may want to choose a more expensive plan with different features, but they could do that if they want to make a decision on price.
This is after the subsidy.
Yes, for most people, but not everyone receives it, which is why the 72, part of why that exists. But so in terms of the problem, what I think we need to focus on, and I think we want to fix, in the marketplace, there are places in the country, in states like Ohio and California, lots of competition. We're not seeing a lot of the large rate increases that we're seeing other places. But there are places in the country where we'd like to see more competition. And we'd also like to see things that settle the market. And we're going to work on those and do those. But the idea of the problem, I think one has to talk about what is the magnitude of the problem. And that's what I was trying to articulate by putting some of the facts on the table. But the other thing is we do believe there are changes that need to occur. And the president articulated those in a Journal of American Medicine article, and he restated them last Thursday. Some of those things are, number one, we need probably to further subsidize the portion. The 15%, if you did the math, the 85 that get the subsidies, then there are the 15 that don't. How do we think about those people? And I think we think that some of that needs to be possibly subsidized. Number two.
Is that the provision that kind of keeps a group of people out because of the 9.5% and stuff? In other words, you need to open it up further for
no, that is for people who are in the marketplace now but are not subsidized. So if you're not in the marketplace now and you're not subsidized, Number one, on November 1st, I'd recommend you shop, but because the premiums have gone up, you might be eligible now. So we estimate about 20% of the people would be eligible that weren't before.
Because the cost went up, so
That's
the
right.
share of income went up.
That's right.
Yeah.
So that they may get those subsidies. But for that other group of people, I think we believe there may be policy changes that need to occur to help them in terms of it. So they're in the marketplace, but don't currently receive subsidies. In terms of another change, the president articulated that we believe that in places where there's not enough or adequate competition, we need a public option so that those people are able to make sure that they have a place in plans and choices and options. A third change that we believe is important is working on high-cost drugs. And there are a series of proposals that are part of the president's budget, but let me just highlight one to give you a sense. One, and one of the biggest ones, is giving the Department of Health and Human Services the ability to negotiate on high-cost and specialty drugs, because that's not something we can do now. So we have to accept price instead of negotiate. So yes, there are things that we believe can be made better. I think we view it in the world more of building on progress, and there are issues. You know, some of those issues have to do with how do we encourage more competition to get lower price, and those are some of the policy approaches we propose.
Let me stay on this for a sec. A number of, part of the problem in some of these states is too many sick people, not enough relatively healthy people, correct? Is that a fair statement? That obviously sicker people are eager to get health insurance, and it's been harder to get in the healthy. Now, some on the right have suggested that if you sort of deregulate a bit, let more young people buy for less, that would actually help change these sort of risk equations. What do you make of that? And what, in general, how do you respond to this? Reduce the degree of regulation or provide a broader set of plans, some of which might not be the specifications of the ACA?
So I think one needs to think through why the premium increases were occurring, because that gets to what solution you would choose to implement. And when we look at the pricing in the marketplace, so the insurers were in a new business. And by that I mean, so the individual market, it's a small market, and it was before. Since the Affordable Care Act, in dollar terms, it's doubled nearly in size in terms of dollars. But it's a pretty small market, but it changed dramatically, and it grew, and what insurers were supposed to do was different. They were now insuring everybody, not just running a business to look for healthy people. And so their ability to price in those early years, they didn't have actuarial data. That's how insurance companies do it. And so if you look at, gets to the issue of what's causing this big price jump this year. If you look at the Congressional Budget Office estimates of what premiums should be charged and what they estimated in terms of running all their numbers, if you took that number and you grew it just at medical trend, that's where we would be now. And so what has happened is there was underpricing. And so, there is a question of what conversation would we actually be having right now had they priced higher then and just grown at the regular rate? Because what people are focused on is the delta, the change in rates. And I understand that, because any rate increase, people, gosh, that sounds bad, and but we need to keep focusing on what consumers are paying, and the other issue of what consumers would have paid had the pricing probably been a little more accurate in the beginning.
Two other things I want to ask, and then I want to move on. And Mo signaled to me when we were opening up to the audience, I hope. You answered one of them, which is a public option would provide an alternative. Why in the world wasn't that included in the first place? Another idea, I think Henry Aaron at Brookings, my colleague, suggested that, and some states have done this, is if you put all insurance plans on the exchanges, on all of the exchanges, you might actually create some of the competition that you need and some of the options that you need. Even the insurance bought by people outside the ACA, basically.
So in terms of the issue of the insurance bought outside, it is one risk pool. They have to treat it as such, and that's part of the rules of the ACA. So those people that are in the individual market that sits right beside the marketplace. It is part of one risk pool in terms of the pricing, and as people think through and work through those issues, it is a part of, they have to view everything together. Are there ways you could do that and have more efficiencies? Yes, and I think those are things that we'll think about, but the base of it is an idea that it is one risk pool.
And why no public option in the first place?
With regard to that question, I was not here in terms of the Washington debate. And so I don't actually know the answer, not that I wasn't here. And it's that I actually apologize, but I don't know. That was a time when I was not here in DC, and so was not following and don't actually know the answer to the question. And I also think it's a fair thing. Whenever we have had major legislation in the United States, you learn and you iterate. That's like what we do. We did it with Part D. We did it with Medicare many years ago. That's what you do. And there's just been no opportunity for that because of the vast divide about this issue. And so I think it is a natural thing. I don't know the specific answer to your question, but I think it is a natural thing that you learn and you improve. And you learn and you improve. And that's an activity that is done with both the executive branch and the legislative branch working together. And that's what I think we're hopeful will happen. And will happen after we leave, but think it will happen.
You actually think Congress will take this up?
What I believe is that Congress, and it's actually not even about Congress, it's about the country. The kinds of things that I spoke about, pre-X, the pre-existing conditions, the on your plans to 26, the fact that actually in insurance, you and I couldn't be charged differently, me more because I'm a woman. Those kinds of things, we're not going back. That's what people consider our healthcare system now. And so in a world where that is true, the alternative we all have is to work together and improve the things that aren't working well. And I think that's what's going to happen in a new administration.
I want to move to opioids because this is a problem. I guess I have two questions. One is, was this not anticipated? To what extent was this slowly happening under the surface and then suddenly exploded to public awareness? And what actions can we take? I mean, there is a bill that's passed, but where did this come from and what can we do about it?
So it was something that I think was building over a period of time, but its recognition, I think, has become much more acute in terms of the recognition of the issue across the country in the last, I would say, 2 years. And in terms of the problem, the administration had been working on it over a period of time in lots of pieces and parts across different parts. And one of the things that we have done is come together around a strategic approach to the opioids issue, certainly in the health space, in terms of key areas that we're focusing on to make sure that you're actually changing the trajectory. And just to give people a sense, and I guess it was 2014 or so, there were 250 million prescriptions for opioids. I think most of you have a sense of the population of the United States. It's more than one for each adult in the country. And so the idea that just can't be right. And so our strategy is based on three things. One is controlling the prescribing, because the prescribing, that's how the drugs, many of the drugs are getting out to people. And so this is about helping doctors. And so the Centers for Disease Control and Prevention has put out a new set of guidelines. The Surgeon General has challenged, how many providers are going to take on and take up those guidelines. And we're working to get those guidelines out. They're guidelines about how to prescribe for pain. And so the idea of the prescribing is an issue. And so there's what you can do to give doctors the tool. There's also making sure that in states there are things called prescription drug monitoring programs. And this means if you're a physician, what happens is you need to, and I come in and ask for one of these drugs, or you think I might need one, you go on and check and make sure that I haven't been prescribed by 5 other doctors. Same thing for the pharmacy. So control prescribing. The second thing is medication-assisted treatment. And it's sad that in our nation that we have so many people that have substance use and misuse problems in our country, that we have to have solutions like this. And this is using drugs and other means together with therapy and other things to treat people who are addicted. And this is a very important thing because it comes to the legislation that was passed. You know, the legislation that was passed didn't address one of the most fundamental things. In the United States, you know, the number of people, you know, who have access to this treatment is extremely limited in terms of the need and the demand. And so that is a very important thing, is funding that treatment. And that's something that the federal government is probably going to end up taking the majority of the share, because states, you know, don't have the capacity at this point to do that. The third element of the strategy is something called naloxone, or Narcan for many people. And that's what you give to people to prevent them from dying, and making sure that there's broad access about that. I'm sure you all read about the number of overdoses in Cincinnati recently, or in Huntington, West Virginia, from a particular type of drug. But it is this drug and getting access. And so the FDA has approved a nasal version, which, you know, might make it simpler for people like me and you to be able to give to people if that's what needed to happen. And so we're trying hard to make sure that it's funded and the right people have access.
A couple other questions I want to ask before we turn to the audience. We have talked, you know, the 1990s, there was an obsession with welfare, and TANF passed. And we have a lot of people now who say we really must care about the poor. There's actually been very little done to reform the welfare reform. Could you talk about that, frustrations with that, and also what you think needs to happen? And then I'm going to violate Hannah and ask one last question, and then I'll go to the audience.
I will be brief then. So with regard to those issues, I think the answer of what has happened and what should happen, it's what's not happened should happen, is at this point in time. And there are two categories that this falls in. One actually is the funding. When you look at what the funding is and what people actually receive, in terms of this being something that is supporting and supplementing people who have children and are trying to make it, those numbers have gone down on a state-by-state basis. And so we do, and the budget has proposed for a number of years, funding increases, and that's important. But the second thing is, we do believe that there are reforms. And interestingly, there was energy around a bill relatively recently, and it's a bill that's a bipartisan bill, but haven't been able to move that through. I think many of the elements of that piece of legislation are the kinds of changes that we think are needed. It's interesting because there's some bipartisan agreement on this. So those are the two things that I think we would need to do.
Last thing I want to ask is personal for me. We got, one day we were talking on the phone about something, I forgot what the issue was, and then we took a long detour, and it turned out that your faith has actually been part of how you approach these issues. And we are sitting here at this great Jesuit institution. Could you talk about that a little bit before I open it up?
Sure. And I am a Greek Orthodox Episcopalian, which is an interesting breed. All four of my grandparents are from Greece, so I was baptized Greek Orthodox. But in my little town in southern West Virginia, of 3,000 people, there wasn't a Greek Orthodox church. There was an Episcopal church that let the Greek Orthodox priests baptize people there. And so...
only in America.
Only in America. But so we belonged, and I was raised in, you know, in a community of faith. This was a very important thing for our family. My father was the lay reader, and delivered many, many sermons. My mother was president of the Church Women for 25 years. My sister was the organist. I was the acolyte and the crucifer. Because our church was so small, it was a mission. It wasn't even a church. We were a mission. I mean, there would be times, when there are 15, 20 people in our church. So that's why I was both crucifer and acolyte, for those of you who actually know those two different functions. And so raised in the faith, an important part of how I think about in my career and what I do in terms of, I'm a fan of the Gospels in terms of a place to turn and receive guidance and think about things. And just, I find that in my work, that's an important part of it. Thinking about the role and how Christ turned things on its head in terms of who he was helping, who he was being connected to, and how we think about translating those Gospels in our day-to-day lives and the work that we do and the lives that we lead. So it is something that is an important part of how I think about my work, both in terms of what I do and how I do it.
Thank you. Did you ever think Job had it easy in this job?
There are some days where I do wonder. I do think, I will tell you, the point at which there were, we had unaccompanied children, we had Ebola, I needed to make the technology decisions for healthcare.gov, and then I am just days in, and of course there was Hobby Lobby versus Burwell. No one had told me they changed the name. That was decided against us. And then I'm not really sure how this happened, but after 50-some years, some smallpox was discovered. And so at that point, I was kind of thinking a little bit about Joe.
The plague is next. We've got a microphone in the middle, and I want to invite people to line up. Thank you. There you go. And if you could identify yourself and try to put a question mark on your question.
Thank you, Secretary Burwell, for visiting Georgetown this evening. My name is John Davis. I'm a senior studying healthcare management and policy. And my question is, how do you believe we can improve health literacy so that people are more informed when it comes to decisions regarding their healthcare?
You know, it's funny, I think this is a very important thing, and it's one of the things around the Affordable Care Act that a couple things. One is, when the people have insurance, you have to convert them to care. That has to, it's not good enough to have insurance. You actually want people getting preventative care and that sort of thing. And one of the interesting things about the Affordable Care, so we do have a whole effort with our stakeholders that help enroll people to make sure that they are educating them about when to use the emergency room, how to use preventative care, and those types of things. But in terms of education and literacy, I actually, interestingly, was with a reporter today. I'm sure you can imagine I've been with a lot of reporters over the last 3 days in terms of some of the issues. But one of them told me, and it was fascinating, what she said was that in talking to consumers, the consumers that are in the marketplace shop. They take time, they know, they are engaged, and that is one thing that I believe the marketplace, while it is only 10.5 million, is leading in people becoming educated about their health care, and part of it is that they have a tool. And so they have the ability to shop and compare. Also in the marketplace, you have an ability to look up doctors. You have an ability to look up drugs if you have certain prescriptions. And so that is leading to a space where we have a more engaged consumer. And that is what is going to transform the system. And I'm sorry, but your question leads to something that's really, really important. And that is the fact that while everyone is focused on the marketplace as the definition of the Affordable Care Act, 5 years from now, what people are going to focus on is what the Affordable Care Act did was give us the tools to support a fundamental change in our healthcare system that's about putting the consumer at the center. And what does that mean? That means, first of all, we change the way we pay. Right now, we pay fee for service. So you're paying for a test, not the outcome, is your mother healthier? And so changing our payment system, which is one of the things we're deeply focused on and trying to do. The second is more integrated or coordinated care and more prevention. Prevention, we've talked about. What does integrated or coordinated care mean? It means that, take for example, a hip replacement. Right now, it's paid for piece by piece. So the person who comes to your house, get rid of the carpets, bring your dishes down. The surgeon, the anesthesiologist, the physical therapist. We're moving to a system where we bundle that payment. And that forces integrated and coordinated care. Because if we're being paid, and you're the anesthesiologist and I'm the physical therapist, and we need to coordinate because I want you to get that patient to me quickly so that we can have a healthy outcome because that's what we're being paid for. So it causes that coordination and integration of care. Lastly is data and information. And right now we have electronic health records, but how they're used by you, the patient or consumer, or by your providers isn't there yet. And these are the changes we need that are going to help us get to a place where that consumer is more knowledgeable, is engaged, and empowered. They can access their health records. They'll be able to have them so that they can ask the questions that they want to ask. So sorry for a long answer, but an important question.
Thank you.
Hi, yes, my name is Zach. I'm a junior in the School of Foreign Service, and I wanted to go back to the opioids issue that we talked about a little bit earlier. And last month, Georgetown hosted a documentary screening with FBI Director Comey and DEA Director Rosenberg. And I thought one of the most interesting lines in that documentary was that the best place for a substance abuser is a jail cell. And I thought that runs quite starkly in contrast to the approach that you laid out. And so I wonder, how do you reconcile the law enforcement side of the opioid issue with the healthcare side that you talked about?
You know, that's a place where I think we've made real advancements, when I say in the last 2 years, in terms of this being a health issue and recognizing that addiction is a health issue. And certainly there are cases and places in terms of people doing things that are illegal and should be a part of our justice system. But for many of these people, this has become a health issue. They are addicted. And therefore, you know, how we think about alcoholics and their addiction is very different than how we think about these types of addiction. And many law enforcement officers, when I meet with law enforcement officers, you know, you've got so many of them that look at you and say, I don't want to be a healthcare worker. I don't want to be a social worker. Give me a place for these kids to go. How many times am I going to have to deliver naloxone? You know, save their lives, and then have no place to put them with regard to medication-assisted treatment. And so I think this is a change, and I will say it has been a change, and for all that the current season has given us in terms of the conversation, and I am here in my official capacity, so not commenting, but what I will say is that in this space, there have been many people who have come out and spoken to this issue that are in places where they were being heard that this is a health issue, and I think that helps us a lot.
Thank you.
Thank you.
Hi there, Secretary Burwell. My name's Roe Haydar. I'm a senior in the School of Foreign Service, and I wanted to ask you about the prices of prescription drugs in this country. Because I know that HHS has undertaken efforts to lower the price of prescription drugs. I know there was a rule change, I think, when it came to making sure doctors didn't have incentive to try and prescribe expensive prescription drugs. But I know that you rejected a letter from from members of Congress who talked about, I believe it was margin rights for drug makers who can make generic alternatives to prescription drugs. And this is personal for me. My mother has rheumatoid arthritis. She has, when she goes to the doctor, her doctor tells her, I could give you this drug that costs like $40,000 or $50,000 per year, except the problem is her insurance doesn't cover it. She couldn't afford a plan that would cover it. And to pay that out of pocket, that's more than a year's salary for her. So I would ask you, what sort of actions can we take to ensure that people like my mother, there are probably thousands, if not millions of people like that, can afford drugs that they would need to make their lives better?
So I think that there are a number of steps that are important to take, and I think that particular step, that is a provision that is applied when things meet that standard. But I think there are some other very important tools, and I spoke to one of them that I think is extremely important, which is the ability to negotiate on price. You all probably, I think you heard, I worked at Walmart. You know, I did the foundation at Walmart, but I will tell you, there's a reason that there's everyday low price there. It's called negotiation. You know, that's what you do with your supplier. And we are, at HHS, we're 1 in 3 of every health dollar spent. And to not have the power to negotiate to help with some of those issues. So that's a very big issue. I think another issue is continuing on the path of generics. And last year at the FDA, I'm proud to say we approved more generics than we ever have in the history of FDA. And we're going to try and continue on that path to continue doing that. And so those are some of the things that we can do. The other thing is the light of day. And while we were criticized for putting up, on our website, on our Medicare site, you can actually go and find out the drugs that are the highest cost drugs and the drugs that have had the highest cost increases. And there are reasons that are complex, and I'm sure you all have seen this in a very recent public example about rebates and what it really costs and that sort of thing. And so we were criticized because that's not really what the consumer pays, and we think that's important. And so the website is clear that it's not necessarily the price, but to put the light of day, because I think we've seen very recently when the light of day is on things, that's when we get a little more help. And you specifically referred to another rulemaking that we have that people have opposed, and it's called the Part B rule. And it is a rule where we believe that you want to encourage people not to prescribe the most expensive in terms of how they're paid, but instead to prescribe the one that is right. And so it cuts across to the earlier question in that delivery system reform. Those are some of the steps. You know, cases like your mother, it just breaks your heart. And what you want to do is try and get these policy solutions as quickly as we can, because we know there are people like that out there every day who, even when they do have insurance, can't receive some of the treatments and things that they need.
All right, great. Thank you very much.
Hi, I'm Henry. I'm a junior in the college studying economics and German. My question is, with regards to the public option, how can a private insurer fairly compete with a government-run healthcare plan that gets to draw upon taxpayer resources when the private insurer doesn't?
So I think
Asked by a good economics student.
I think that the question there is, I think as you've seen in our proposal, it's about where there isn't competition. So in a case where private insurers aren't willing to go in, that's when you can't get folks to be in that kind of space, I think it's important to be able to provide that kind of assurity. And I think you can design in ways that there can be competition in terms of how you design. And so I think it's an important question. I think it's why we put the issue out there, because then the question becomes, so I think that's an important question, and I think that's one of the key things you have to figure out, can you design correctly? Because then the real issue is so what's the alternative? So you can regulate really heavily in terms of regulating the insurers to make sure that they go in and they provide. That's another alternative. You could have no coverage for people. And so these are complex issues. And one of the things about healthcare and working in this space, incredibly complex, incredibly hard. Teddy Roosevelt was like one of the first presidents to talk about healthcare reform, and we've been working on this for 100 years. But so I think your question is one of the right ones in terms of how we think about design. But I think the other thing we all have to think about is, so what are the alternatives to a public option? And really, it's very heavy regulation is one of your answers. And so which of these things do you think is a better place to try and encourage a healthy market? Because that's what we want. I mean, that's what we're working hard to create, is a healthy market where issuers come in and compete with each other. And we see that working places like California, places like Ohio and other states.
We got time for one more question. These are great questions, by the way. Thank you all.
Hi, Secretary Burwell. Thank you again for being here. My name's Connor Maitner. I'm a senior in the college here at Georgetown. So my father's an insurance broker, and the Affordable Care Act has been a topic of conversation in our house for a long time as a result of that. But I was talking with him just yesterday, knowing in advance of your visit, and talking to him about some of the concerns that he's seen in working with folks and navigating since the rollout of the law, and as folks navigate the exchanges and the market and so on. And this does kind of follow up on the previous question. We didn't plan that, I promise. But he mentioned one of his concerns that he's seen being, as you've seen carriers now recently announce that they've been pulling out of certain states. And so it gets that idea of competition that has been brought up, and I think that you've said clearly you see it is a concern and you're looking to address it. And then another concern of his, though, that he mentioned was the idea that people have a difficult time with plans where they're not able to see the doctor or the hospital of their choice. And that's been kind of a difficulty in the rollout. So I'm curious, kind of following up on carriers pulling out of states, but then also that idea of seeing the doctor of your choice. Is that a concern of yours? Do you think that's something that can be worked on going forward?
So in terms of the question of seeing the doctor of choice, I think rising up to the larger question of satisfaction. And so satisfaction with marketplace plans, as done by external consumer organizations that look at employer-based plans, the satisfaction rates are about the same. And so one of the things that I think tells a lot of us, and this question of narrow networks, which gets to the issue of, is your provider in the network? The trade-off is price and network generally, and that's the trade-off. And in the United States today, we see more and more consumers making that choice on price, and therefore what you see is the issuers, the insurance companies, making choices and decisions about that based on consumer demand. Having said that, we think it is an important issue for consumers to know and understand. It goes back to that earlier question that the gentleman asked about the consumer having information. And that's why last year we piloted, and this year we're sort of advancing the idea that you can do doctor searches, so that as you're signing up for a plan, you can try and understand, is your doctor on it? Or in the case of a pharmaceutical, if your drug is on it. And so what we want to do is get as much competition as we can. And that competition isn't just with issuers, that competition is actually also with providers. Because that's how you also get the next level. Because when you don't have competition at the provider level, you have less competition, generally speaking, at the issuer level. And so those are some of the things. And does it concern us? Yes, we want to make sure that the consumer can get the product that they want. But for many consumers, this becomes a price, breadth of network kind of trade-off, in terms of a broader network is a more costly one, generally speaking. And so we're going to continue to work on these issues. The consumer is generally speaking with their feet, voting with their feet in terms of these issues, but always looking to understand. And the other thing is, the Affordable Care Act requires that there's network adequacy. And so there's two different things. There's, can you see the specialist or thing that you need to see? And that has to be met by anyone who participates in the marketplace. It's a different question of, it's the person you want and like, and finding a plan that matches. And so we're going to continue to try to make progress on those issues, but those are some of the core trade-offs.
Thank you very much. I want to just ask you one last question, and I'm going to set it up like one of those college applications where you can answer. This is about coming here for a PhD.
If I
you
answer
can
correctly, do I get in?
No
GMAT,
or maybe
no nothing?
So you can answer one or the other, or you could bring them together. Because I wanted to ask you, your successor asked you, what should I focus on? What should I worry about? What public issues should I really worry about? Or a citizen asks you, what do we need to do to make the country more just? And if I could draw on the Constitution and the old name of your agency to promote the general welfare, what would really make a difference? And you can go either way, or maybe you can bring them all together.
In terms of my successor, what I would tell my successor is that I think it's very important to continue the changes. And this gets to this delivery system reform part that we were talking about, because it gets to the affordability and the quality, some of the last few questions, that these are the kinds of changes we have to get in the system in order to get more affordability and quality, which start to get to some of the problems that people are raising and some of the concerns that we have. And so I would say, number one, focus on that and making sure that that goes forward. Number two, I would say focus on the importance of relationships and focusing on the customer. And sometimes the customer in our rulemaking are doctors and physicians. And sometimes our customer is a Head Start kid. And sometimes our customer is a university trying to get a drug approved by FDA. But having the customer at the center of the work of HHS is extremely important, and that brings me to the citizen and the things that we need to change. I think that is one of the things that we've tried to instill at the department, is this idea that actually, who are we there to work for? It's not about the policy or the program, it's about what I like to refer to, and at the Gates Foundation we called the boss. And we did that because I had this picture of a child, and she's 2 years old. Her name's Ndiaye. She's from Senegal. It's a picture, she's taking her bucket bath. For those of you, and I heard a number of you all in foreign services, you all have studied development and everything. Kid's not particularly sad. She's just sitting in the bucket taking her bath. That's what she's doing. And this picture is a picture that I gave to everyone that joined the global development team. And I wrote a note saying, looking forward to the impact you're going to deliver for the boss. Because the idea of focusing, who is it? And this little kid on your wall. So everybody had these pictures, and I'm sure you can imagine at first when I did this, Bill and Melinda Gates were like, the boss, isn't that like us? But everyone adopted that this was the boss, and this idea of who do you work for? And I think that ties into what we need to do to make the nation stronger and more just, because so many of our issues are about the everyday issues that people live, and whether it's, if you have older, for you all, it's older grandparents, and the administration for community living, or someone in Head Start, and it's about the education of their child, or if you do have a parent who needs drugs, and whether that's at the research end or the access end. So much of our work is about that. It's across the board in terms of what we need to do every day. And so that's trying to bring those two things together in terms of what I would recommend to a secretary and what I think we need to do. And the healthcare issue, because it connects to people's very core of what is one of the most important things that you have every day. And the other thing is it connects to your finances so deeply, continuing to make sure that we're creating a space where people can have that affordable quality coverage.
Well, thank you very much. Thank you so much. I want to thank the Institute of Politics for setting these up. I think we've had more policy in the last 90 minutes than we've gotten out of an awful lot of the campaign that we've just gone through. And I'm also grateful to you and to the Institute, because I think one of the hardest things to do now, because you get very little respect, is to work for the government of the United States. And it bothers me that so many young people are so reluctant to join this, and we make it very unattractive to them. And I think you helped us see that it can actually be quite exciting, and I thank you for your work.
Thank you, and I do want to encourage all of you. This is my moment for my ad to consider work in government. Bobby Clark, one of your alumni, is here, who works on our team and does incredible work for us. But I just want to encourage each of you. You can make a difference, I promise you. The kinds of decisions and choices and work that you can do every day can affect millions of lives. And so I just want to encourage each of you all, as you think about what your future holds, as you think about summer work, as you think about how you think about what your career trajectory wants to be, I really do want to encourage each of you all to think about it. I've had the chance. I've worked in philanthropy. I've worked in development. I've worked, worked across the board. And government is a unique opportunity to work on change at scale. And so I just ask each of you to at least think about it as you think about your futures. And thank you so much, EJ, for being here, and thanks for having me.
Thank you.